I talk about the near-death experience that I put patients through every week as they're about to go into the medical coma of anesthesia. And there's a powerful healing potential in that space. And I always want patients to speak up so they're comfortable and advocating for themselves in that precious time. But I don't always think that it goes the way that people are expecting because of the unusual things that people can say. So, to make this less intimidating, I want to share some of the things that folks might tell me, even though they don't remember what they're saying when they're in that limbo of awake and unconscious or altered state of consciousness. And the classic one is, Doc, are you single? The last time this happened was actually last week. It was a woman, I believe in her late 40s, and she was having an elbow surgery under what we call MAC or MAC. It stands for monitored anesthesia care. So it means they weren't under general anesthesia with a breathing tube. They had something like a little face mask like this, so they could actually still speak if they wanted to. The problem is that if you're speaking and trying to ask your doctors these types of questions, maybe myself or the surgeon, or heck, one of the nurses as well, it can interfere with the surgery, especially if you're trying to make hand motions and the surgeon's working on a part of your upper arm. You could actually interfere with the surgery. You could hurt yourself by accident as well. There's actually many different medications that we use in folks who are having this twilight sedation or the MAC, monitored anesthesia care. Propofol is a common one. It has, I find, the most propensity to put people into this more talkative state. There's a medication called Precedex or dexmedetomidine, which is, I find, much less likely for folks to be talking under. Then there's ketamine, where folks are kind of like in a different plane of existence, far less likely to talk about stuff, but they might remember things in ways that would be perhaps unusual. Hey, Gabby, I see your comment. We're going to talk about nerve blocks in the second example in just a second. So just hold on for 1 minute. The question that I have to answer whenever a patient starts to flirt during surgery is, do you make the anesthesia deeper or do you make it lighter? I'm really curious what you think, because the surgeon always asks me, what are you going to do, lighter or deeper? What's your intuition? I'm going to look at your comments here. Straight talk for certain, Lizzie. I like it. While you're answering that, the conundrum is that if you make someone too deep with anesthesia, sure, they'll stop flirting with you and talking, but they may also stop breathing. That's a problem if you don't have a breathing tube in place, because they were supposed to be under sedation, not general anesthesia. If you make it lighter, well, they might begin to remember parts of the surgery that they probably don't want to. They might feel more of the surgery, which you don't want either, but you might make them less disinhibited, if you will, so that they can safely have the surgery. So like Al says, it depends on the situation. Sometimes I need to tell folks that, hey, we're going to go a little bit lighter because I really need to make sure you're not too disinhibited and moving around and trying to make hand gestures about what you want to do on tonight's date or stuff like that. You wouldn't believe the stuff that people say or do. Then sometimes we go deeper. If I'm not worried about them, for example, if they don't have sleep apnea, and I'm not worried about them obstructing their breathing, maybe we can go a little bit deeper so they can kind of get out of the talkative range of anesthesia and more into the sedated range. But there's a reason why folks will often tell me, don't tell me what I say when I'm having surgery, because sometimes this can happen. Really, it's an 80-20. 80% of the time, folks are in maybe that healing place, in a relaxed, sedated place. 20% of the time, it can be a little bit more talkative. And now I'm looking at folks' comments. Lizzie agrees. Don't tell me. Understandable. The second patient, and this is where the nerve block comes up, Gabby. This was a while ago, but I'll never forget it because the patient told me this before they even got the anesthesia. They asked me for extra anesthesia kind of under the table. It was a young man for a routine knee surgery. And the real problem was when he became very adamant about wanting to go home with the IV in place. Do you know why that's so concerning from the doctor's perspective? Please let me know in the comments. I want to see who can nail this, because this is really gives me pause and might affect what I do for the anesthesia if they want that IV in. Oh, Lizzie, Stephanie. Yeah, so Thea got it here. Drug user and abuse. The problem is that if you're getting an IV home with you, well, then what's to stop someone who might be struggling with addiction or substance use disorder from using that IV for less than wholesome purposes? And they could be dangerous. So in this case, I actually spoke with a surgeon and said, hey, there are some red flags here. This gentleman needs to have this knee surgery, but I just want to avoid opioids or avoid maybe euphoric type anesthetics as much as possible. So I said, we're going to do a nerve block. In this case, I actually did a spinal, but the concept is that you numb the area fully so that you have the IV in place for an emergency, but you're really not planning on using it. And instead, it's there as that backup, not for delivering medications that someone might have a propensity towards liking. That might be a potential trigger for using things outside this setting. So there's a lot of depth and nuance that goes into this. That's the bird's eye view. But the point is that I'm going to avoid the breathing tube. I'm going to avoid, this mask anesthesia with sedation as much as possible, and just provide the pain relief without the sedation and the IV. And then there is the invitation to go home with the patient. So for many reasons, the doctor should not say yes here. This is important because there is all sorts of ethical and moral concerns here, especially if someone has the effects of the anesthesia that's contributing to them saying this. The problem, this was actually, I'll get to the problem in a second. This is a gentleman before going under general anesthesia. So it's not that he's having sedation and kind of chit-chatting the whole time potentially, but when someone first comes into the operating room, but before they get the breathing tube, you have to be very deep and unconscious and paralyzed to tolerate having a breathing tube placed between your vocal cords. It's very stimulating, very painful. So you got to go from like 100% to 0%. I don't like to go in just one go like that. I want to first have them come in the room, give them a little bit of something to relax, go from maybe 100 to 75. It's in that 100 to 75 range where people might start to chit-chat a little bit. So not when they're fully unconscious, because once you have the breathing tube in place and it's between your vocal cords, you can't phonate. You can't speak even if you wanted to, because you just can't move your vocal cords enough to produce voice. So it's in that, maybe it's 2-3 minutes, when someone is kind of getting primed to go to that 0% consciousness for surgery, that you get some questions like this. And it really comes down to this, like, what's the last thing you remember? Because I asked him when he woke up, I didn't want to prime him and say, oh, do you remember asking this? Or you just ask. And it's very curious how little folks will remember, even if you don't give them the mind erasing amnesia medication that we call midazolam. Very small amounts of anesthetic when someone's anxious has this interplay together where they often don't remember what happened. It's also curious how people fall asleep influences to a degree how they wake up. Folks that fall asleep with like a little smile, which you see sometimes, or sometimes even crossing their legs like they're in a spa setting. Very curious, I find that they tend to, though not always, they tend to wake up more relaxed as well. So I kind of want patients to be chilling there and kind of kicking back. Now, I don't want your legs crossed because that can put pressure on the muscles and on the soft tissue over the bones for extended periods of time. So we're going to uncross them after you fall asleep, but you can fall asleep that way. I'm not worried about it. I want you to be comfortable. I'm curious now with 3 of the top stories that I've encountered in the recent last couple of weeks. What do you remember saying? Do you remember what you asked? Would you want to know what you said and what your anesthesiologist responded? I'm very curious. I would love to hear your experience as well. And remember, if you're learning something new, hopefully you're recognizing that this is not uncommon. I don't want you to feel afraid of this before surgery. I don't want you to be afraid of the anesthesia. I want you to know what to expect. And maybe you can prime your doctor by saying, hey, could you please not tell me, or certainly not record it or tell anyone else. We do say it's Vegas rules in the operating room for a reason. So I wouldn't want you to be concerned. Elle, good to see you. I would love to give someone a good laugh if it's appropriate, for sure. Ambrose said, I feel nauseous. He said, here we go. I hope you received some anti-nausea medication as well. Kaylin, I remember asking the OR nurse if they were bringing me a case of beer. I've never had anyone ask me that. Nervous about intubation and TMJ problems. Vicky, fortunately, when you get the breathing tube in place, because we paralyze the muscles in the jaw, there tends to not be that much damage that one's going to cause because you really relaxed all these muscles that often produce many of the TMJ symptoms. That being said, I want you to tell your anesthesiologist certainly what your concerns are so they can try to be as gentle as possible with the intubation. Under a piece of moon. I just had a parathyroidectomy. My anesthesiologist was Iranian, and I started talking Farsi with him. I lived in Iran with my ex-husband. That's a funny one. Does EDS cause issues with intubation? Typically, no. Brittany, hello back to you as well. Stephanie, I was scared of having my colonoscopy and going under. Been a while, and allergic to propofol. They asked if I was allergic to lidocaine as they were putting me out. I said, I hope not. Well, sounds like if you're here, you probably weren't allergic to it. A propofol allergy is very, very rare. I'm curious, Stephanie, can you tolerate egg or baked goods? If you're comfortable sharing, I would be very curious to know. Baked goods or eggs? Straight talk, good to see you. I told my consultant before he performed my surgery that he looked a lot older. Oh my gosh. Why would you say that? After being given fentanyl because being put to sleep for a surgery left you a bit traumatized. Wow, well, I'm really sorry to hear about that, Jessica, but I'm grateful that this content helped you heal from this and grow from it and hopefully become more resilient from it in the end. Brad, 2 months ago had a hemiglossectomy. First time being put under. Well, I'm sorry you had to have that surgery. I hope the reason for it is something that's being addressed well with the surgery. But I'm so happy that you had a positive mindset and you woke up feeling great. A lot of folks like to sleep. That's right. That's right. I had a surgery. It's a long one. After I woke up in recovery, the nurse had asked me if I had sleep apnea. I wasn't aware of it. She suggested I get a sleep study. Yeah. I'm going to have another one. Well, I hope that it is something that's readily treatable if it's obstructive, certainly either with the CPAP or with oral appliance. Hey, peace and love back from San Francisco. Oh, breakfast at my grandparents'. That's a very beautiful thing to think of before going under anesthesia. I'll say that some folks do have experiences with passed on members of their family. It's not very common, but I've seen it a couple of times, and it can be very meaningful for folks. I wouldn't want to attribute a specific meaning to that because who am I to speak on that? But it is curious that there can be a healing potential in many of those interactions. So yeah, some of it is kind of giggles and jokes like what we're talking about today, but a large part of this provides a potential for much greater healing. I certainly hope that you all learned something new. If you did, please hit that like button, share what you learned with others, and subscribe to keep up with all of my medical content. And remember that you have more power over your health than you've ever been told. And I always want you to advocate and speak up with your doctor. And if you're going to speak up and say silly things like this, know that at least you're not alone because it's quite common before anesthesia. Until next time.